You'd want to have them bend forward, hold that position or bending forward and create a muscle contraction, whether it's squeezing your core, whether it's holding your body up against gravity, leaning forward, as long as the apex, the best you possibly can, is specifically where the most of the curvature is in the lower back, which is tough to do. So whether you put a pillow underneath your stomach and well seated and you're leaning forward, and then try to brace the core, squeeze the muscles in your back, 5 seconds to 10 seconds on and off at a light contraction will also help bleed the energy into the backside.
Where you can do maybe uneven surface training, unstable surface training, perturbation exercises. It's where you're maybe balancing on one leg and someone's just softly pushing you from one way or the other. You're trying to steady your balance. It's a great way to start to push yourself in kind of that neuromuscular segment, which is important too, not only just for spinal muscle activation, but for proprioceptive activation. You need to be doing isometric holds, those kinds of exercises daily.
Yes, and activation.
Exactly. So it's trying to be specific for your issue.
Yes.
Welcome to the Functional Code, your go-to source for decoding optimal health. Join Dr. Addy and Dr. Jace as they break down the science behind pain, performance, longevity, and more, making complex concepts easy for you to understand and apply in your life. Your journey to a healthier you begins with understanding the Functional Code.
Welcome back, everybody, to the Functional Code. We are super excited today to bring you guys a new episode. We're talking about spinal instability. This is actually an incredibly common cause of back pain. It's usually missed. Not a lot of providers know how to look for it, how to measure it. And there are just a lot of things that comes to how to manage this condition. And we see it all the time. And so this is something you guys should check out if you've been having issues with your back, if you have a history of already instability, ligament laxity, feeling of uneasiness or apprehension. This is going to be a great episode for you guys. So as always, I am Dr. Addy.
And I am Dr. Jace. Yeah, we're going to go over a bunch of different conditions that can relate to the spinal instability. A lot of the common ones that we see on an everyday basis, anywhere from spondylolisthesis, retrolisthesis, even we'll get into a couple others, very specific ones that are a little bit more niche, and then even to some treatments on how to go about it and how we look at things as well. So if you ever wonder like why your back aches, why your posture's off, or why even some people feel like they bend like a pretzel, you're in the right place, especially with people that feel like they have a lot of tightness throughout their whole body. The tightness is usually a guarding signal that is more from underlying cause on that side.
And those individuals that can stretch in certain ways that definitely other humans can't, almost a contortionist. You almost feel like you can do those kinds of things. As cool as that is, that's now a sign of instability or hypermobility. And along the way, it can become a problem if you don't correctly train, obviously.
Absolutely. So I think the first thing that we want to get into is what is spinal instability. There's a textbook term for it, but I think it would almost be better for us to go what our 2 cents is and what we've noticed thus far with spinal instability, other than what we've already touched on and talked about. So I guess for myself specifically, anytime there's compromise to the whole structure, whether it's degenerative changes where arthritis plays a factor, or at a younger age, that there's, Doc said, a lot of bending, hypermobility to where you can move way more than you should be able to. And the protective mechanism is to either tighten up or affect the pain receptors, thus where a systemic pain can come from, or localized pain as well. There's actually, where some of these other conditions we'll get to, there's also an immune system misregulation from sometimes on a genetic component, which can also affect these hypermobility, connective tissue
ligament
disorders.
strength, all those kinds of things.
Yeah.
And the quickest one is, I think it's Benton scale or Baton scale, if I can't remember what the gentleman's name is, but it's like a quick 9-part test that you can do at home. The first one, I think, is can you touch your thumb to your wrist? If you can do that's already, pretty easy sign. Can you lift, I think it's your pinky up to a 90-degree setting? Can you bend over and touch the floor with both hands is another one. I think there's some other movements that you can do at home, but it's a 9-part test, very quick. You add up your score, and if you're over a certain number, there's a good chance you have this ligament laxity, instability somewhere in the body or in the entire body.
Yes.
Definitely go and get checked out for Ehlers-Danlos, other types of connective tissue disorders. Because again, if you want to stay active, you want to even play sports and do all these other things, you're now at a risk of injury because these parts of your body aren't as protected. Things are a lot looser and not as strong.
Yes.
Yep.
Really well stated. And I think when we go into some of this too, you'll start noticing with certain conditions that we'll dive into that, and we'll also state the reason why there is instability with some of these. So that can come from the causes of just arthritis, like we said. It can come from genital conditions when someone is either birthed into this world or happens at a very young age. That can also be a cause to this instability. Even from something from car accidents, sporting injuries, especially traumatic events, can cause this instability on the ligaments. And that then, if we don't stiffen up the ligaments, the muscles overlying it will act as the guarding mechanisms. That can only last for so long. And then there's compensations that go, honestly, for years on end as well.
And if there's usually a fracture,
Yeah.
then now that area, if not healed properly, put down weaker tissue, weaker bone, and you're stuck with that until you train out of it. Try to increase, like you talked about, training different parts of the body specifically.
Yes.
And then because too many times I think people tend to overtrain the tissues that aren't helpful for stability. Muscles are great for movement, but it's the tendons, it's the ligaments, like you've talked about,
100%.
where if you don't train those, in this scenario, you're just not protecting that injury now, unfortunately.
Yeah. And we'll get into certain specifics on the treatment side of things. So we'll get to that on that
Absolutely.
side of things. So it's going to be fun there. So I guess let's dive into some of these conditions. So when we go into some of this, there's a lot of different specifics, but we want you guys to know the general gist with some of these, and you actually might fall into some of these categories, or at least potentially some of the first ones that we'll talk on.
Yeah.
Because these are some of the more common ones we see on a day-to-day, week-to-week basis. So the first one I'm going to start with is a spondylolisthesis. Now, when you look at the spine, specifically from one bone in your back, one vertebrae, to the top and bottom, there's a disc in between. And on the back side, if you're watching on the videos, there's a yellow cord that comes all the way down. That's the spinal canal. Now, the spinal nerves also go out from the canal out into the body to organs, which helps supply different types of function throughout the body. So when you look at the structure, spondylolisthesis is where the bone slides forward on the bone below or above. And that's where we can either have a couple different things occur. On the back side of the bones, there could be instability on what's known as the posterior longitudinal ligament, and that could also be causing muscle guarding and or pinching off the nerves, thus either for lower back symptoms down to the legs. For the neck, it'd be symptoms to the arms. It could also affect different symptoms of breathing, heart palpitations, different stuff like that. That is one to where one slides forward, but there's also another condition, retrolisthesis, where the bone slides backwards. And in fact, that's between anterior listhesis or spondylolisthesis, either or retros. I more common see retros in my clinic or retrolisthesis. And this is all in a grading scale. So grade 1 is anywhere from 0 to 25%. Grade 2, 50%, 7,500. So you can see where we're coming from, the grading scale in terms of how much it slips. So that's where you'd want to go check either x-rays, sometimes MRIs, CT scans can pick some of this up too, but that's where you want to see a physician. So if you have pain going down, especially both legs or both arms.
For long periods of time.
Yeah, on and off, or the pain's got better and it keeps coming back. That's another sign as well. Even like bending forward can elicit symptoms either down to your legs or arms. That can be another one as well. There's a few different things like that. Usually if there's radiating pain out to the extremities, there could be certain potential symptoms related to these conditions.
And also, if you did gymnastics as a youth, that's probably one of the most common causes of what's called a pars fracture, which can cause the anterior listhesis.
Yeah.
So if you've been having these symptoms and you were a gymnast when you were younger, now we have two big correlative experiences that could signal instability in the spine.
And I actually like that you brought that up. Anytime cheerleaders, dancers come in, especially after, let's say, their 20s, mid-20s, 30s, there's a lot of like muscle guarding tightness because they don't have the bendability, the flexibility that they're used to at a younger age. They stop, they grow on and move past the dancing, cheering career. And that's where the overlying muscles are starting to tighten up because they don't have the protective stabilization of the deeper structures and what we were talking about. So good point. And even going back to the slipping forward and backwards, like it could be due to degenerative changes. Like even when the disc starts to break down, it can either slide forward or backwards.
With retros, that's the first thing that I worry about is a disc issue.
Yes.
Very commonly, someone will have an experience where they bent over and felt this back just seize up. Maybe it went down their leg. It just depends. We do an x-ray, there's a retro, and now I'm like, okay, there could be, it's tough. With x-rays, of course, you don't see the disc. You can't see the actual anatomy of the disc. You can see the space and you can make predictions, but you can't truly see what's going on. But with the retro, there's a good chance there might have been a disc injury. So then an MRI might be warranted. We have to look further. But that is another sign of you either herniated a disc or something happened.
Absolutely. There's different types. It's pretty much going back to the bones sliding forward or backwards. It can affect the discs, thus affecting the nerves, and thus why muscle tightness occurs, thus why certain symptoms can occur. Between those two, spondylolisthesis, either or, and then a retrolisthesis, those are two very conditions that can affect a lot of people. Even if you don't realize it, you may not have symptoms, but if you've been injured in the past or in certain sports that are a little bit more physical, or like we brought up cheerleading, dancing, all these different types of things can affect the underlying structure, and the pain is the last thing to present itself. That's why you want to pay attention and get checked on a consistent basis.
If you've been injured.
Yes. Yeah, good point. Now, let's dive into the next one, Ehlers-Danlos Syndrome, or EDS. Now, this is a common one for hypermobility. Now, and actually when I was going through this, I did not know there's 13 different types.
Yeah, I think they're starting to categorize more and more different types. I think either it's just different gene expressions that they're finding now. I don't know if there's mutation or what have you, but yeah.
Interesting.
Or they're just finding more and more types of it, and now they're just creating more categories.
Which makes sense. It's EDS. It weakens the ligament supporter on the spine. It's often due to a hereditary connective tissue disorder that it can also affect skin, joints, even blood vessel walls, which is unique. But it is back, like Doc said, to a genetic mutation affecting the collagen and the protein structures, thus leading to the skin and all these other areas being hypermobile. That's where, going back to some of the tests that Doc said in terms of touching the thumb to your wrist, bending forward, you're going to have a lot of flexibility. But even from a practitioner standpoint, the tissues and the muscles will have a lot of give and stretch. So that would be a good sign on that side that you can potentially start looking down this avenue. So with the 13 different types, I'll put some of these up on the screen so you guys can look at them. The most common one is the hypermobility and chronic pain. This can even start at a very young age, especially around the time of puberty, as the individual grows and accelerates their aging process through puberty. That's where you start noticing all these other changes, even more injuries that can occur just from like random, just simple movements like bending down the tire shoe at a young age and something gives out. Certain small things like that can affect this as well.
I'm actually treating a D1 hockey player right now who has EDS.
Oh, interesting.
And definitely more sore than usual, and maybe compared to their colleagues. That's just one thing that they have to deal with, unfortunately. More prone to injury There's more, they feel like there is times where the knee can give out, have that occurrence, we'll call it. But they definitely are still very competitive, and
That's awesome.
it doesn't limit them. It's just you're now more prone for injury, unfortunately. So you just have to do your best to train hard, keep things intact, those kinds of things. But it should not, these kinds of conditions, they don't always limit you in that way. And it's still important to work out and train with EDS and other connective tissue disorders. It was interesting when I found out about that.
Yeah, I got a patient too, same thing at EDS, and the tough part with her is she also has jaw instability, which is it is a challenge to say the least.
Yeah.
And we'll get into some of the treatments, but you have to be very specific on the shifting and in certain ways. And I don't know if you remember us talking a while back, like when we were working out that one time with some of the jaw stuff, clenching the jaw while opening actually is working wonders.
While opening.
Yeah.
Yeah.
And then go, depending on what area or what way the jaw deviates and or tilts, you want to go either in neutral position first, like having them look into a mirror, holding clench or tension as they're opening the jaw slowly, neutral, and then as that becomes easier, then they go ideally open a little bit opposite, all the way opened, and then back to center. So
It's
slightly
clenching the
open,
entire time.
shift or tilt, open, and then back to center.
Clenching the entire time.
Yeah.
Yeah.
Very slowly.
Yeah. I'm having my one TMJ patient do that protocol where it was open and then clench and then go each way as she's clenching to force energy to that capsule that you talked about. She's been doing really well with that, by the way. I haven't been able to talk to you on, but that's awesome. Gonna get her to my dentist now. My dentist does really great TMJ stuff, and get her night guard, protector, those kinds of, she hadn't really got that far yet, but yeah, I'm seeing so many jaw cases now. I feel like once we dove into it, like the universe just opened it up now. And
Forgive us.
It's been great, man. It's been great.
That's cool.
Yeah, it is. It's awesome. I don't think a lot of people get help jaw-wise out there. They don't. They really don't.
It's like not much out there, which is unusual, especially dentists. I feel like
and
they
that's
should
the
know
crappy
that
part.
more.
I asked every one of the jaw patients that I get, and I'm like, you got a dentist? Did your dentist say anything? They're like, no. They say it's just is what it is. It sucks because I feel like that should be a specialty that should be like breathing for you. Like it's a huge thing you should be able to assess and manage. So
they're right there.
Yeah,
Like
you're it. But
makes all sense to me.
Yeah, no, it's been great.
Yeah. So going back to EDS, so if you start noticing certain common symptoms, so for people at home have a general understanding, it's like chronic pain, either soft, stretchy skin, bruise easily, poor wound healing. It can even have GI issues like irritable bowel syndrome, or your stomach, you don't digest food as well. And then even for POTS, or what's known as postural orthostatic tachycardia syndrome, to where in certain positions, blood flow can be restricted up to the brain, which can affect either lightheadedness.
Yep.
It can affect pooling of blood into the legs, sometimes fingers, cold hands, cold feet. My wife actually has POTS, and it's interesting to see how to manage the symptoms on a day-to-day basis.
For sure.
So that's
be really tough.
Ongoing thing on that side too. So we know that side, even cardiovascular issues, especially from arterial ruptures or the pliability of certain blood vessels. If you bruise easily or if you stretch quick in certain positions, there could be other complications that can come from that as well. So,
and one thing on POTS really quick,
please.
If you're a female and you never had any issues at all with fainting or feeling uneasy or lightheadedness, and you got COVID in 2020 or any of around that time, and now you have these symptoms, I would go get assessed for POTS. So they're finding that's a huge driver of a POTS diagnosis right now. They say that I think it's over 80% of women are getting the POTS diagnosis, and it's highly correlative back to COVID diagnosis in 2020. The virus is creating this regulation in our nervous system, dysregulation in our nervous system that didn't have that before. Now, some people had symptoms and then it was exacerbated by COVID too. Some people actually had POTS and now their POTS is really bad. So if you are a female and you had symptoms, you didn't have symptoms or had maybe some symptoms and it was exacerbated by COVID, I would go get checked for POTS if you've been really having issues.
Especially when it comes on a gene level too. Like, that's interesting.
I've had at least 5 or 10 now since 2020 that I've sent to get diagnosed, and they've all been diagnosed.
POTS is really hard to diagnose
It
too.
is.
A lot of practitioners don't have
the tilt table or other things that you need for, I usually send to a neuro. They usually have everything.
That's beautiful.
But yeah.
Yeah, that is EDS. Now, in terms of the treatment management, a lot of it is managing the symptoms, and some of this stuff we'll get to, whether it's certain isometric contractions in certain positions to bleed that energy of that muscle contraction into certain ligaments, tendons, muscles. We'll get into some of that as well. But that's just really good to know in terms of actually what is EDS. Now, there are other things that you could look at in terms of diet modifications, like avoiding inflammatory foods, electrolytes, hydration. Like, there's a bunch of like common things. If you get the foundation right, you're going to be just fine on that side of things. But those are just a few things that I want to touch on a little bit there. Now, as we go through some of these other conditions, they're all partially relate to spinal instability. We're just not going to dive into those as much. So one of which is known as Marfan syndrome. And this is a genetic disorder affecting connective tissue and can also cause ligament laxity. It also increases the chance that the vertebrae can dislocate much easier. There is that one. There's osteogenesis imperfecta, which affects the bone density and structure, which increases the spinal fractures or can increase spinal fractures. This is one I don't even remember learning in school. If we did it, maybe it was on one slideshow and it was there. Ehlers-Danlos Syndrome. I don't know if I said that right.
Ehlers-Danlos, maybe?
Ehlers-Danlos. Okay. I apologize if you have this condition. I pronounce what we pronounce it wrong. A lot of it is due to spinal instability, due to vascular and ligamentous abnormality. So there's that. And even as we go into, as the disc breaks down or degenerative disc disease, like I said, that can either create like sliding forward or backwards of certain bones, which can relate to the spondylosis, retrolisthesis. And then even facet syndrome. So facet syndrome is wear and tear on the facet joints or the joints of the spine. And that can also cause hypermobility pain and also can lead to other forms of arthritis as well. And then ankylosing spondylitis, or that is a type of inflammatory arthritis that leads to spinal either rigidity, but it can also cause spinal fractures with trying to force mobility, especially if you don't notice that.
So that's almost the opposite. It's so unstable because it's so hypomobile and there's no give. And I think that's an issue.
And people try to force the stretching and they force it so much that the structure gets out.
Something can get injured.
Yeah, and then we have spinal stenosis. So if you look from bottom up or top down at the spinal canal, either the central canal is narrowing or the space where the nerves come out of the spine, foraminal stenosis, that's where the narrowing can also occur as well, which can also lead to shifting. It can lead to like either scoliosis, which is another one we're going to get to, where there's curvature of the spine either side to side with rotated segments as it twists all the way up and all the way down. Then even post-surgical instability. Now, I know we've seen a couple cases to where they put these spacers in on between the spinous processes or the bones that you can feel on your back, which open up the space of the nerves going out to the spine. However, there's a few things that I don't know if they realize the long-term implication to where if you increase the space on the backside to help with the nerves, it can also lead to instability on the front side and cause either really bad retrolisthesis or spondylolisthesis, which can also break down the disc and create this like instability in that direction as well.
And other types of surgery procedures where there is a fastening of some sort, whether it's a fusion or even removing parts of the bone as well. You're now adding instability in other ways. So if you've removed things, now there's less material there to hold it in place. Or if you're stabilizing or fusing, it may be helpful at that segment. You have to worry about segments above and below because now they are taking way more force versus having that help of its adjacent segment.
Very true. I like how you said that. Was eloquently stated. And there's a bunch of different types with that too. And this is nothing against the surgeons. Like there's a time and a place for surgery, but it's having a general understanding of if they go at the spine surgically, affect your spine, you have to know there's going to be compromise on either the complete 180-degree side of the structure, just locally or systemically, the body compensation wise, or there's going to be breakdown in some way long term on that side.
And then, of course, not to forget all of these very small tissues in the spine that they might have cut to get to the spine. And we are going to talk about just how important those tissues are in a little bit here, but that has to be one of the scariest, is the atrophy of the multifidi and a lot of other tissues where if you don't regain that, stability is very difficult to regain.
Very true. And that's where specificity comes into place incredibly well from the practitioner or physician standpoint. And then just to round out with some of the instability, it can also be caused due to trauma, especially if someone already is compromised with instability. For any of these other conditions, you get into a car accident, you're playing in sports, and it can create way more risk of long-term damage or potentially fatal damage, which no one would ever want. And even it's curious for some people, instability can also come from tumors or metastasis, which can weaken the structure as well. So that's usually coming later stages of life.
If it got into the spine, creating a pathological fracture or something like that.
Yeah. If you guys have questions, comments, concerns, comment below.
Yeah, we'd love to dive into any of those more in depth. We'll probably hit a few of those in the next pod, but
for sure.
Yeah, please let us know.
So, Doc, in terms of measuring the spinal instability, what have we seen and what ways? Because I know we have x-rays in our clinic. There's functional x-rays where you can see some shifting. What are some of the other ways or ways that you look at instability?
Yeah, so in terms of just spinal instability is where we are going to be measuring. EDS is, again, different. We talked about the Baton scale. That'd be a place to start. And then, of course, they do a lot of blood work, other types of tissue measurements for EDS. That's separate from what I'm talking about. This is more, again, looking at anterior and retrolisthesis, looking at possibly ligament damage. We can look at it with someone had whiplash or cranioscervical instability. All these things that we can get unstable joints from an issue. And how do we measure that? So actually the easiest way with, I guess we'll call it ease of access, is an x-ray. It's very non-invasive. There's not a lot of worry to it. And we do what's called a flexion extension radiograph. So we have the patient, if we're looking at their neck, we're going to have them look all the way down. We'll take the image. We'll have them look all the way up. We'll take the image. And then we can see, was there any translation of that vertebrae forward or backwards? And we can actually see it really quickly within 30 seconds. And that is a nice specific way for us to hone in. Did they have an injury from that car accident? Or if it's in the lower spine, we'll do the same thing, have them flex, extend. Do they have an injury in the spine that's causing the anterior listhesis, the movement, or the retro translation? And we've been able to detect that very quickly if there is some type of involvement there.
Even, Doc, I started checking out a couple things. So car accidents, getting hit from the side.
Oh, yes.
I also have been doing some more in recent lateral flexions to see shifting. Because there's an individual that just came to us, got hit from her right side, and it actually led to a trauma-induced scoliosis. And now there's instability on the mid-neck C5.
So was there some horizontal translation as well? Yeah.
So I went to flexion, and you can see there's a way more hypermobility movement all going through the C5 segment, especially tilting, and then also flexion extension.
That would be so cool to have. I don't have it on this list, but a fluoroscopy or a digital x-ray digital motion x-ray, excuse me. And that is where you don't need to, you don't have a still image where you can take the x-ray. This one, it's just running full time and you're just seeing as they move in real time what that segment is doing. And I think it'd be phenomenal to have an imaging device like that.
They're so sweaty though.
They are. But I have seen this gentleman on LinkedIn. He has them in his clinics, and just to see in real time what that vertebrae joint looks like as you flex it fully, and then you get to that point in time where it shifts almost, and then it shifts, and you have this, I guess we'll call it threshold, where it's maybe being held at a certain amount of flexion, but once it gets to a certain amount of against gravity is when you actually see the translation. And that also is helpful to see just how unstable it is, because if you're getting translation with even a tiny bit of flexion already, it's very unstable versus needing a lot more gravity and weight against it to get the unstable shift. So that is just us nerding out on that right now. But
Cool.
for patients who need, I guess we'll call it more in depth, we can do an MRI. If they have what's called a modic change on the MRI, it just could be correlative to spinal instability, and that is usually what will show up. Now, if they have metal in their body and they can't do an MRI, I had this with patients before, we'll have to do a CT instead. And we can see, again, certain changes with a CT. Obviously, if there's fractures, that's a sign of instability, but any degenerative changes, things like that, we can still use CT for. There are some other types of MRIs that you can do. Upright MRI actually can help find certain things that a supine MRI wouldn't be able to, especially if there's slippage. And then lastly, an EMG or a surface EMG. This isn't specifically for vertebral bodies, but it's for the paraspinal muscles that we just talked about. So
interesting.
you can actually go in and you can see altered muscle activation, especially around the spine, like the multifidi, transverse abdominis. And if they're not activated, we now know that there was a direct injury to that area, and there could be instability, which can affect their pain. This can be after surgery, this can be after trauma. However they want to go in and measure that, they're starting to do that and showing good correlative change.
Interesting. I would love to try some of this stuff.
I would love to do this with everyone who had an ablation, because I think, and we'll get into this in a little bit, but I've had so many patients now, young patients who've had ablations in their 30s, and they're seeing and they've had no change in their pain, and they've seen everyone. And I'm like, have you ever done specific PT for the small tissues? We've tried to work through, and they've said no, they didn't even know about it. Their ortho never told them about the long-term effects of an ablation, all these other things. And I think we're going to start seeing a real issue with patients who are having ablations long-term, and the real instability that it's causing. And I'll bring up some studies here in a little bit, but this would be a great way to check to see if there really was a decrease in activation of those tissues. And knowing we got to hone in on that.
Love that.
Yeah.
And even when you're looking at x-rays, especially, I know this is more for physicians, anything grayer, for me, when I look at things greater than 2 millimeters of slippage forward, backwards, or side to side, I look at that as instability.
Yeah.
For sure. Some places will say 3 millimeters. I talked to 2 radiologists, one she's very pronounced in the space. She says 2 millimeters, so that's where I'm going off there. Just 2 cents I wanted to throw in for certain physicians on that side.
It's good to know.
Absolutely.
Usually of course, sometimes the radiologist will just throw in that it's trace movement, like trace retro or trace anterior. And you'll want to look at the images yourself, because sometimes they'll use the 3 and they literally 2, and they won't have put that on there. They'll just put trace.
Yeah, or even some, they don't even realize that it's even a thing or how it can contribute to the symptoms.
Or they just didn't measure it.
Yeah, there's some people some radiologists, I think it's more, I don't even know. It almost, for me, could be potentially just medical doctors looking at it and they're looking for abnormalities. No, it's all fine, but there's like a 4 millimeter shift posterior, so retrolisthesis. They're not accounting for that, and of course, something's missed.
Yes.
Happens more often than you believe. May believe. But yeah, so Doc, I'm curious. Let's get into some of the treatments. I know we've been talking about like what it is. Let's get into some of the nitty gritty. And then along the way, we'll give our 2 cents
Yeah.
as well on that.
So if you have spinal instability, if you feel like you're hypermobile, if you've been diagnosed with EDS, if you have any of these, we'll call it conditions, here's the kind of first line conservative treatments that we would recommend. So you need to be able to do deep spinal stabilizer workouts, exercises, physical therapy, we'll call it. And a lot of people will call it just core stability work or other types of spinal stability exercises. And it is really making sure that we are targeting the core muscles, but also the spinal stabilizers, the pelvic floor, multifidi, all those other things. And systematic review, this is an RCT, also showed core stability exercise improved pain and function in patients with lumbar instability. This was Punjabi in 1992. Other protocols that have popped up over the years, McGill 3, Big 3 has been, I would say, a great place to start. It's easy to do at home. It's a modified curl up, a side plank, and bird dogs. And usually you'll do those at a certain set and rep. And the last one would be motor control exercises specific just for these deep muscle activation. And Doc, maybe you would want to touch just a little bit on what some of those controlled exercises look like specific for kind of the spine.
Yeah, so you would almost want to put yourself into certain positions. This would be slightly depending on what condition you have, whether it's EDS, whether it's scoliosis, whether you're having the bone go forward or backwards. That'll all depend on what therapy and what target you want to address. Either way, when you first start off with, there's going to be more than likely for 99% of the patients we see with this. I haven't noticed anyone that doesn't have overlying muscle guarding tightness because of the nervous system's protective mechanism. Ideally, you'd want to get the overlying muscle tightness under control first. Usually, you'd want to start a couple different ways with this one. In terms of core stabilization, we're going to get to that in a side rabbit hole, if we will. But we first want to start off with general mobilization, pain-free, as biggest range of motion that you can possibly control. If you're able to move excessively past and into pain threshold, then just decrease it, go in at a very slow pace, and or after time progressively building into holding on and strengthening around that line of tightness or around that line right before pain. Over time, you're going to then create stability around the deeper structures of the spine, thus build up the stabilization. So you'd start wanting to go workspaces or full body mobility at the same time as either doing other different modalities of turning off some of the overlying muscle tightness. That could be anything from trigger point therapy, from cupping, scraping to a certain extent, will also help. In that same avenue, pin and stretch movements with massage can help a lot there. But more of the results are going to come from some of these like active motions and active types of therapies where your nervous system's connecting down to the tissues. It's not passive where someone is moving your arm for you or...
We want you to engage tissues.
Yes, yeah. Even acupuncture with stim or electrostim on those needles can also engage some of the deeper tissues. You have to be somewhat cautious. You want a skilled practitioner that has a lot of experience with acupuncture.
You don't want to go around a lung or anything like that.
Oh, for sure. So you'd want to first start turning off overlying muscle tightness at the same time as creating mobility from the deeper structures. Now, as the pain subsides, as you increase range of motion, or you're able to go farther with less pain, that's where you start wanting to be very specific. Now, whether that's scoliosis, whether that's Spondylolisthesis, I'll get into certain specifics with that. And that's where, let's say we have a spondylolisthesis to where for the lower back, if those that are not watching, that are just listening. So we'll say for right now, this L4 bone is sliding forwards, okay? One of which is happening. The ligament on the backside, posterior longitudinal ligament, has too much give. It doesn't have the stabilization. And the disc potentially could go backwards and affect the nerves, thus create either pain, weakness, tingling down to the legs. That is where, as the symptoms get slightly a little bit better, you want to bleed that energy to tighten up that ligament. Now, how do you do that? Ideally, you would want to go to length, pain-free, so that for this example, you'd want to have them bend forward, hold that position or bending forward and create a muscle contraction, whether it's squeezing your core, whether it's holding your body up against gravity, leaning forward, as long as the apex, the best you possibly can, is specifically where the most of the curvature is in the lower back, which is tough to do. So whether you put a pillow underneath your stomach and while seated and you're leaning forward, and then try to brace the core, squeeze the muscles in your back, 5 seconds to 10 seconds on and off at a light contraction will also help bleed the energy into the backside. More or less, when you go into this, you want to feel a little bit of tightness locally in the lower back for this example to create those changes. And you need that for ligaments. They heal at a rate of months. So there has to be consistent weekly to keep working on this. And that's where it's tough for the long-term approach, because not only do you need to stabilize it and need a lot of time for probably a good solid either 8 to 18 months of working on the structure and then general maintenance long-term from there. So that's going to be another one. You would also want to not only address the shifting backwards of the bone of the L4, and that would come in means of going into spinal flexion, or it would be segmenting each bone one by one and then going backwards and do like a push-pulling mechanism to where then you go back to a cat-camel while squeezing your core as well. So that can also create some of the changes, but that has to be done in a progressive manner. And it's also different. Let's say you have curvature of the spine. That changes the angles in which you have to either move your body, tilt, rotate, so you can be very specific to go at some of the apex curvatures. We'll get into some of that when we get to the scoliosis podcast, but that just gives you a general understanding from there for certain conditions like that.
So it's going to be a lot of isometric holds.
Yep.
Is that kind of where
or
a lot of
slow lengthening?
Yep.
Yeah.
We're really trying to target smaller tissues. We're not concentrically trying to build big muscles, or it's very slow, very targeted, very finely held. And that's really going to be where you're going to start a lot with a lot of these motions and movements.
Yes.
Yep.
100%.
Yep.
So yeah, that's where I'd go with. There's a few other things that you can add in, bracing and stuff like that too. But yeah.
Perfect. Thank you, Doc. Cool. The next kind of segment is proprioceptive neuromuscular training. When we have breakdown in certain tissues, we lose proprioceptive input. That just helps us balance, helps us tell us where we are in space, and especially around the spine, that you need good force stability. And so this would be where you can do maybe uneven surface training, unstable surface training, perturbation exercises. It's where you're maybe balancing on one leg and someone's just softly pushing you from one way or the other. You're trying to steady your balance. It's a great way to start to push yourself in kind of that neuromuscular segment, which is important too, not only just for spinal muscle activation, but for proprioceptive activation. Your proprioceptors also help protect you from falling in balance. These are really important, especially if we're getting older or if we just had a surgery. Now we're more prone for those kinds of things. We want to help restore that motor control. So balance board exercises, vibration plates, perturbation training, one-legged balance. There's so many other things. I'm sure if you look up proprioceptive training, in the spine itself, Doc, do you have any? It's a little bit different in the spine, maybe more from the pelvis side. You can do some easier things, but
if you do like positional holds on a vibration platform or like plank positions while bracing your core, your arms are on a vibration platform, and like side planks and yoga positions, you can get into some of that specifically, but it's
a little
challenging,
more difficult. You'll definitely want to still do for the pelvis, the hips, the legs, those kinds of things. Still makes a difference.
Very true.
Next, manual therapy. We'll call it manual and manipulation, because both are very helpful. There was a study that I read that, and this was a gentleman who was a chiropractor, so he's a little biased, but he was arguing that one of the only ways to truly activate the multifidi tissue is with an adjustment. And he argued that multifidi activation comes from this almost fast twitch-like mechanism that's what engages the activation very intensely. And one of the only ways you can truly do that is with an adjustment, is because you're able to rotate, fast twitch, and you'll get this activation.
Interesting.
And he goes, that's why it's one of the better ways to improve spinal stability is to get adjusted regularly. And we've known that. We've known that there are definitely positive benefits to getting adjusted. We've known that people get stronger, feel better, have better motion. But the way that he broke it down in terms of the multifidi activation, it was very interesting. I never heard that before.
Neither have I.
And I loved that he, stated, and I don't know if that's true, where it's one of the only ways to, do multifidi activation due to that mechanism.
Yes.
Because I think there might be other ways to activate a multifidi without rotation. I'm not sure, but
I'm thinking like AcuStim.
yeah,
Acupuncture with like stim, so it activates it electric.
because they are spinal rotators, right? They're very deep spinal rotators. So I get the whole, that purpose there. But I think it was fun to see the actual breakdown of why it is so effective in this kind of setting. We definitely want to improve segmental mobility, segmental stability with manipulation, with manual therapy. This is what you just talked about, cupping, all those other things. We're trying to break down the muscle guarding, trying to regain function in that sense. Anything with that, Doc?
No, yeah, I think you hit the nail on the head, and I know we touched on certain specifics. A lot of this will come down to being very specific with the rehab. As long as you know the general premise and kind of order and how they go about it, then you can be very specific, like I said, on for that person or individual.
Absolutely. If you're you don't need to be static stretching all the time. That's almost what you don't need. You need to be doing isometric holds, those kinds of exercises daily.
Yes, and activation.
Exactly. So it's trying to be specific for your issue.
Yes.
Bracing is next. We love bracing, but we always like to mention to our patients that it is temporary.
Yes.
It's not something we want you to get used to. For those who really do have severe instability, a brace can be a night and day difference of pain relief for them. Wearing that starting out for the next few months while we're starting to help them build, retrain. And then once they are strong, reducing that amount of time they're using the brace, and eventually if they can get off of it and only need it for maybe a flare up or something like that, that's the end goal.
Oh, 100%. Absolutely.
So it can absolutely reduce pain, but of course long-term use can weaken the stabilizing muscles. That's the only thing that we're really worried about. Anything with that, Doc?
No, I agree wholeheartedly. If you rely on the brace long term, you then create atrophy for the small stabilizers in the body. But you also want to make sure that you're in that process, you're turning off some of the overlying muscle guarding, so you're able to create rehab for the deeper structures. So it works hand in hand to do rehab at the same time as using the brace. And as you slowly work out of rehab, you should also slowly work out of the brace as well.
Yes.
Or prior to.
Yes. Yeah. Absolutely. Next, with any pain management strategy, patients are going to ask for relief from medication. And we do our best to work with patients. I know it's no fun being in pain, so we understand, we get these questions, but a big one is NSAIDs or acetaminophen, and those are probably the two most commonly used. Now, in the short term, it can help, but long term, both uses have been shown to cause a lot of issues. One here I actually showed long-term NSAID use is linked to DJD, disc degeneration.
I can see that.
Now, long-term NSAID use can also be linked to stomach ulcers and issues with the gut. It can delay healing. Acetaminophen use can have liver damage, other types of issues there. If you look on the back, and a lot of people don't know this, I loved when this doctor told me to do this one time, because I had no idea. He goes, look on the back of an ibuprofen bottle, and what does it tell you? And if you haven't looked on the back of an ibuprofen bottle, it tells you, if you are using for longer than 10 days, seek out a physician. Seriously. Why? Because they know after 10 days that it can cause damage already.
Yes.
And now I ask patients, how long have you been taking ibuprofen? No, a year or two every day.
Oh my God.
And it's just sad that they didn't even know that. They didn't even know to look. They didn't even know it was there. And these are just things that we got to do better at helping educate people, because there are a lot of people who have true issues from taking these long term, and it's causing them a lot of stuff. Yeah, that would be, the more common. I'm sure there are other pain management medications used out there, but those are just the two most common, Doc. Anything with that?
No, I think you hit the nail on the head with that one.
All right. So for those of you guys that are looking for more advanced procedures in pain management, there definitely are other injections that you can be doing. Now, there are some studies that show what's called prolotherapy can actually strengthen ligaments and reduce that segmental motion. These are done by more advanced professionals that are very good at injecting. They have usually an image guidance of some sort. They're, let's say, for example, their common thing we see is craniocervical instability, where the top bone that's next to your skull, in a way, can become loose or unstable. And they actually have the ability to go in around that area and inject the ligaments that are causing kind of that instability. And the Prolo itself has been shown in certain research studies that it increase ligament stretch, strength, and improve function in those who have instability. So that's actually really interesting, because it's a great passive way to try to improve that. Not to say you shouldn't be doing the active measures at the same time, but this is just a way to improve that support. Next, we have radiofrequency ablation. Now, for as far as pain reduction, RFA has been shown to be very helpful in selected patients, we'll call it, because you want to make sure that they do the proper diagnostic injections first, which is usually a series of 3 injections around the facet joint to see if you actually get pain reduction, and that's when they do the ablation. Now, we're going to talk about why RFA is something that you should heavily think about first before doing, before you go through with that. So, and then lastly, we have surgical intervention. So if there is a very extreme instability, there's maybe grade 3 or 4, yes, surgery could be an option, should be an option. But until then, we would recommend you avoid surgery at all costs. It's just due to the fact that, and we'll talk about that in a little bit, but the tissues that get harmed during surgery, all the worry of adjacent segment disease, the continuation of degeneration, and all the other things that can happen after surgery, we would just really make sure you try other efforts first before you do fusion. Replacement is another one if there is issues with the disc. I haven't seen a lot of cases with that. I've seen one, and it wasn't a good case, unfortunately, in my experience, Doc. I know you had one case where it actually was pretty good.
Yeah, it was actually decent, and was able to get a little bit of motion in that segment after a period of time, especially turning off some of the overlying muscle guarding. And it actually worked really well, but I think take that with a grain of salt.
Yeah, it's tough.
Yeah.
I don't think there's a lot of people who are doing it, and those that have done it usually sometimes go to Europe and get it done. I don't know if there's I don't know if they're doing disc spacers or replacement here in the United States yet. I'm not sure.
Not sure either. I know disc space is probably the replacement. So
yeah.
No.
And then lastly, interspinous process devices. This is for, again, just another way to reduce instability in certain cases. They say it's not as effective as fusion for severe instability, but it can be used for more mild degenerative instability. Again, Doc was talking about going in posteriorly, and when we are doing that, it can cause further degenerative change and motion instability if not managed properly. So, so I did bring up a few studies that really shows why spinal fusion and RFA, or radiofrequency ablation, can be worrisome in the long term. Spinal fusion eliminates motion at the fused segment, but increases stress on adjacent segments, which can lead to adjacent segment disease, meaning you now have force distributed elsewhere, and it puts excessive force on that. It's almost like a dysregulation of force. And now we have the ability for degeneration to happen and worsening of that instability, because now we're worrying about instability in other places, and it's accelerated in fashion.
Yeah.
Now, they showed that a systematic review by Radcliffe in 2012 found that 30 to 40% of patients develop adjacent segment disease within 10 years of lumbar fusion. That's a very large population. The fused segment no longer moves, causing hypermobility and accelerated degeneration in adjacent levels. They also showed that 26.6%, this was a different study, 26.6% of lumbar fusion patients do require an additional surgery within 10 years due to adjacent segment issues. There is also paraspinal muscle atrophy, which has been documented following fusion, especially in the multifidi muscle, which is crucial for spinal stability. And then lastly, artificial disc replacement may reduce instability at an adjacent level degenerative compared to fusion, but again, I would call it a very experimental surgery at this point, and I don't think we have much on it. In terms of fusions and surgical operations regarding the back, again, we're worried about what's going to happen long term, and that is just something that if we can avoid, I would recommend.
Yeah.
Doc, anything with that?
Yeah, everything that Doc you said was so important, but I think the general gist, the main concern that we have, or that you should have if you have spinal fusion, for those that are not watching, if you would take in consideration, I'm holding this model, but in place of, it would be like a spinal fusion. Okay, and you try to create motion around it. If you lose motion in the segments that are fused, it forces compensations above and below, or the adjacent segments. And that's where it can also create that hypermobility, because then it forces more stretch on the ligaments above and below and the front and backside, which thus creates this instability, and thus also why after you have spinal surgery, you're probably going to need maintenance long-term, or potentially other spinal surgeries long-term from there, mainly because of this specific reason.
And what does it also mean? You might get your pain back.
Yes.
And now you have a horrible fusion in your back, and you have pain back. And you did it to help in the short term, hopefully long term, but if it doesn't come long term, now you're stuck with a fused back and limited in more ways than one, and now you're up against the stream again.
Weightlifting, mobility.
Exactly. The next one I wanted to bring up was radiofrequency ablation, and I just read a study the other day, and 2024 study, and I'll bring that up here in a little bit, but 2008, facet joints limit excessive spinal motion by ablating their innervation. Patients may experience uncontrolled movement due to loss of proprioception and muscular control. And these are certain nerve branches that they're denervating, which helps with the pain relief, but those nerves do also have a purpose. And to get to those nerves, when they're burning them off, denervating them, it can also do that to the adjacent muscles and tissue. So we're getting atrophy, increased instability over time. Next, the multifidi muscle atrophy post-RFA. There was a study in 2020 showing that the RFA can innervate the multifidi tissue, causing multifidi atrophy, reducing spinal stability. And then this was a big one done in the Journal of Pain in 2024, and it was titled Asymmetrical Atrophy of the Paraspinal Muscles in Patients Undergoing Unilateral Lumbar Medial Branch Radiofrequency Neurotomy. And what it showed was very strong evidence that RFA leads to paraspinal muscle atrophy, particularly in the multifidi, which is, we talked about that muscle a lot today, but it is a crucial muscle needing activation and strength. And if we don't have that, it really will cause spinal instability long term. Now, what it also showed was it increased fat infiltration of the multifidi. And that means that where the muscle should be, fat went in place. And that's a problem because we now don't have the ability to activate tissue anymore because no fat's in place of that. Actually, it also showed a substantial reduction in muscle size, suggesting atrophy. And then regarding specifics, and just lastly, that it disabled key stabilizing muscles that led to increased instability over time. So I just really wanted anyone who is thinking about this, unfortunately, who have had this, if you have had it, it's not the end of the world. Now we just have to be way more specific with training, and we need to rebuild what has been turned off, unfortunately, with this procedure. But Doc, anything with that?
Yeah. Hearing this study changes my mind on this type of modality therapy for certain individuals, especially if they're having pain long term. Like, there's a time and place for it, but before having this, you have to ask all the questions of, in this specific area, what could the potential possibilities be? Obviously, we see from this study that atrophy long term of the muscles that are supporting the spine, if they're not able to support it, everything's going to give out from there, and everything could get worse long term. So ideally, you'd want to find someone, more of a PT chiro, that knows and understands how to train the small muscles along the spine. If you find and know one there, you probably want to stay with them long term.
Absolutely.
Yeah.
I would say that's going to be a more frontline on the kind of cutting edge of understanding how to treat these issues. And if they're talking about, ask them specifically, what are you going to target? Which tissues? How are you going to do that? And if they don't have an answer, they're probably just bringing you some general PT, very non-specific, and it might not be what you need in the long term.
Love that point.
Yeah.
Very smart point on that one. Yeah. Interesting to know, but I'm glad that we have research that it's coming out to give us some insight on that.
Yeah.
multifidi too.
Yep.
Yeah. All right.
Well, everybody, we appreciate everything you guys have continued to support us with, the comments, the suggestions. We really do take those seriously. We want to make sure we give you guys each and everything, all the value to move forward in life, along with all this information that's really easy to get lost in out there. So we hope that today was super valuable for you guys. Please do like, comment, and subscribe. It really does help us out. And until next time, Doc, you guys have yourself a great day.
Disclaimer: the content provided in this health podcast is for informational purposes only and is not intended as a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition. Never disregard professional medical advice or delay in seeking it because of something you have heard on this podcast. If you think you may have a medical emergency, call your doctor or 911 immediately. Reliance on any information provided in this podcast is solely at your own risk. The creators and hosts of this podcast are not responsible for any actions or decisions you may take based on the information presented.
Thanks for joining us on The Functional Code. For more evidence-based health insights, subscribe, rate, and review wherever you get your podcasts. Remember, your journey to a healthier you begins with understanding the functional code. Until next time, stay well, stay informed, and embrace the science of living well.